Hi, we're Team 18, and our team does a device for intrathecal pain medication delivery and spinal cord stimulation for treating chronic pain. It's difficult to tell who's suffering from chronic pain. It can affect almost anybody, especially those suffering from some form of cancer. Chronic pain is caused by any disease that affects the somatosensory nervous system, such as lesions or tumors. These cause a hypersensitivity in the nerves, which lead to a sensation of long-lasting pain. This can affect the ability to perform physical activity, the lifestyle, and the overall quality of life of the patient. About 20.4% of US adults suffer from some form of chronic pain. The graphs below show the distribution of chronic pain between different groups of people. The left shows the difference between male and female patients, and the right shows different age groups. Up to 30% of terminally ill patients, including those suffering from some form of terminal cancer, report that they have not found adequate pain relief yet. In terms of economic costs of chronic pain, the cost is estimated to be about $560 billion when accounting for both the medical costs and the missed work days due to the pain. Also, the mechanics and processes of chronic pain are not yet fully understood. So at this point in time, it can only be treated rather than cured.
Another reason that the issue of chronic pain is so prevalent is because of the other methods that are used to treat this pain. Many patients use oral, transdermal, or intravenous drugs to handle their pain, but this ends up creating long-term dependence that decreases the patient's quality of life and ends up being quite expensive. Drug addiction and dependence is a big issue, and in order to avoid these problems, you have to attack it at its root by finding other methods of pain management. So, intrathecal drug delivery is a method of pain management where a pump is used to deliver pain medication directly to the spinal cord. By delivering the pain medication to the spinal cord in lower doses, this is how patients avoid the side effects of the drugs, but give it a quick onset of reaction rather than that of like an epidural delivery, which would have a slower onset of reaction. This will end up limiting opioid use, which increases quality of life and the amount of spending on pain management drugs. Other factors that have been linked to better quality of life on intrathecal drug delivery include decrease in pain levels, better physical conditions, and a better ability to move, as well as the capability to do more activities. In one specific study, 86.4% of patients reported a better quality of life, and 0% of the patients actually had stopped taking transdermal or long-acting oral opioids. So there are current therapies on the market that use intrathecal drug delivery, although there are some issues that tend to arise during treatment. The Prometra 2 and Synchromed 2 are some examples of these devices, but some of their downfalls include the development of inflammatory masses, infection at the site, and the catheter becoming disconnected. So the inflammatory masses are an issue that need to be addressed because as they appear, they can start to suppress the spinal cord, and issues related to the catheter can also lead to cerebrospinal fluid leaks. So we want to make sure that these problems are all addressed. But intrathecal drug delivery in itself does not work for everyone. Patients may not be strong enough, and the effects of the treatment may not have the effects that are wanted. And this is why spinal stimulation therapy is used in conjunction with the intrathecal therapy. So, spinal cord stimulation is typically delivered through a small implanted device that provides low electrical stimulation to the epidural space in the spinal cord to provide pain relief for patients by blocking pain signals from reaching the brain. A few small studies show that when neither worked alone for the patients, 91% of them said they enjoyed the treatment, and 100% of them reported a better quality of life when the addition of the other device was incorporated. We have decided to combine the two into one device, and therefore one surgery will only be needed, and we are going to improve the patient's quality of life, reduce their pain, and this is specifically for cancer patients.
There are multiple parts of the device, so we will start with the main part, the drug infusion pump. The drug infusion pump is implanted in the abdomen. It is made of titanium due to its proven use in this application, as well as its biocompatibility and easy processing. The device also contains a small silicone fill port that is reached with a needle through the skin that leads to a drug reservoir which holds 20 to 40 milliliters of medication, as it is meant to last the patient up to 90 days. There is also a pump inside the device that pumps the medication upwards into the catheter port. There are electronics inside the device that control the stimulation and drug dosage and timing. These electronics also communicate with the outside controllers, one that the doctor has to control dosing and one that the patient has to control their own treatment within the bounds set by the doctor, such as turning off the spinal cord stimulation to drive. There are a few more components on the outside of the device as well. There's a place for the electrodes to connect to deliver stimulation on the outside of the device so that the electrodes can be exchanged easily in a minimally invasive surgery. There's also an improved catheter connection to limit disconnections that uses a screw and latch mechanism. The catheter screws into the device like a typical catheter, and then a small latch is locked around it. The device is meant to contain morphine since it is the current gold standard for treatment and one of 3 drugs approved for this use by the FDA. It is also the most common. There is an established problem with pump site infections in intrathecal drug delivery devices, typically due to surgeon error, but not always. So on the outside of the pump is this sol-gel coating that is loaded with vancomycin, which has been shown to be effective against Staphylococcus aureus infections, the most common type of pump site infection. Next is a catheter. The catheter connects to the device and is inserted into the intrathecal space of the spinal cord to deliver medication. It is made of silicone rubber due to its use in other similar applications, as well as its indication for use in neurological drug delivery applications. The catheter has a cap due to its problem with inflammatory granulomas. Inflammatory granulomas are caused by high doses of morphine that can drastically alter the pH of the local cerebrospinal fluid and cause harm to the surrounding tissues. In a 4 vertebrae radius. The cap is silicone rubber as well. It is long enough to extend over 4 vertebrae and full of small holes for the medication to exit out of along the length of the cap. The final piece of the device is the electrodes for delivering electrical stimulation to the epidural space of the spinal cord. The purpose of this is to provide pain relief by blocking pain signals from reaching the brain. The electrodes are placed in an epidural space of the spine and have a modern panel design for increased flexibility and sensitivity. The electrodes and lead are one piece to limit disconnections and are made of platinum iridium because of its favorable impedances as well as its thinner fibrinoid capsule formation.
So to summarize, the primary advantage of our device when compared to traditional therapy is the improved pain relief over traditional methods. Other advantages include the limitation of catheter disconnections, site infections, and inflammatory granuloma formations. Our device also has a greater potential for pain relief due to the introduction of another mechanism of action. Some disadvantages of our device include the high initial cost and invasive procedure when compared to traditional therapy. It also will likely still need revision surgeries despite our modifications simply due to the nature of the device. And there are also many other problems with intrathecal drug delivery that we did not address. This table shows the cost comparison between conventional therapy for chronic pain and intrathecal drug delivery. While intrathecal drug delivery is initially an expensive therapy due to the device and the surgery for its implantation, due to the reduction of doctor and hospital visits and the lower doses of medication required, it actually saves patients money over time. While we have made some modifications to our device that would make it more expensive than traditional intrathecal drug delivery, we believe our modifications will balance out the need for revision surgery. Also, our device has the added benefit of spinal cord stimulation, which has been shown to get a significant number of patients back to work due to the mitigation of pain.
As far as engineering criteria, the device must be biocompatible and not cause a reaction while inside the body. As well as being biocompatible, it must be able to last inside the body for up to 10 years. Depending on the patient's situation, the duration may vary. The reservoir part of the device must be suitable so that it can hold 90 days worth of medication, and the catheter must be able to carry medication from this reservoir to the intrathecal space, and our newly developed catheter cap must lower the concentration of morphine in the local cerebrospinal fluid to avoid inflammatory granulomas. The spinal cord stimulation aspect must have the electrodes that carry the stimulation to the epidural space, and this must run from 0 to 20 milliamps and 2 to 1200 hertz. All of the components of the device must not cause any adverse tissue reaction, and the antibacterial coating on the device should degrade correctly to prevent infection. As far as functional testing, we will ensure that the electrical current is correct, which will be tested with an ammeter in vitro. We must also test that the stimulation provides adequate pain relief in animal models, and that the animals don't have any adverse responses, and that it's safe for them. Within the animal, as far as the intrathecal injection, we can test for pain relief. We're going to monitor the drug concentration in the cerebrospinal fluid, and we want to ensure that the modifications that we have made are reducing the formulation of granulomas. And it's important to keep in mind that testing for pain on animals is not going to be one-to-one as it would in humans, because pain levels in animals are measured by their stress and their behavior. So in humans, their pain levels are simply measured by asking the patient for a rate of their pain.
There are separate tests to determine the local versus systemic response of just the implant, not the medication, as those are separate tests. For local tests of the pump site and catheter, a representative sample of the device is implanted in a small animal and compared with a material of which the responses are known. The surrounding inflammatory cells are also characterized. For systemic testing, there are multiple steps, and systemic effects are caused by the leaching of materials from the implant into farther reaching tissues. First, a test of ion release can be performed in vitro, and then the released products can be tested in small and large animal models, or the entire device can be implanted in a large animal for a more precise test.
For the cap, catheter, electrodes, pump, and the antimicrobial coating, we'll be testing the hemocompatibility and cytotoxicity of all these materials following ASTM standards. For testing the hemocompatibility of these materials, we'll be following ASTM F2828-19, which tests if certain materials cause the activation of platelets and thus the formation of thrombi when in contact with blood. For testing the cytotoxicity of these materials, we'll be following ASTM F0895-11, which tests if materials either cause the inhibition of cell growth or cause the deformation or lysing of nearby living cells when in direct contact. So, to summarize, our device is an improved intrathecal drug delivery device that works in tandem with spinal cord stimulation, with the added benefits of an improved catheter connection to the pump, a catheter cap which prevents the formation of granuloma, and an antibacterial coating which prevents site infection. This design will be more cost-effective in the long run, while also providing improved pain relief over traditional intrathecal drug delivery, and also needing less drug over a period of time. And that concludes our presentation. We look forward to any questions you might have.